stay home, which I think was a smart thing to do because the roads are brutal and we have a ton of snow outside. I'm looking out there right now, so I'm in my living room by the fire, and I have one of my cats joining me back there as well. Oops, on this side. There you go. So today I'm going to talk a little bit about a lot of things. I'm going to talk about prolapse. I'm going to talk about the hypopressive method, which ties into prolapse. I'm going to talk a little bit about surgery, and kind of what prompted that was some of the posts that were in the group recently. One in particular, there was a member who had posted about finally going in to see her pelvic floor physio, which that challenge, which I think is awesome, and I'm super happy that so many people have been taking her up on that on the challenge. I believe that every single woman should see a pelvic floor physio annually, even if you have no symptoms. But anyway, in this person's case, she was told she had a bladder prolapse, and it was a stage 3, and that the person she saw said there wasn't really a lot they could do now because it was more advanced, and there was really only help if it was a stage 1 or 2. So I just want to chime in on that point a little bit, and I guess I believe that it can be improved regardless of the stage. So in prolapse, I don't have my sweatshirt here, but I'll use this one. I don't know if it'll be as helpful, but it's not going to be. Okay, just pretend that this is this part of my arm. This is the tube of the vagina, and at the top of the vagina we have the uterus and the cervix, and this is the front wall of the vagina. Actually, well, yeah, for me it's the front wall. I'll just keep it simple. There's the bladder here, and this is the posterior or the back wall, and then we have the rectum. And so in prolapse, what can happen is the bladder, uterus, and or rectum can shift out of their optimal alignment, and they can start to descend into, in the case of the uterus, or bulge into, in the case of the bladder and the rectum, the vagina. So here is the pelvis, and inside there's the bladder, the uterus, and the rectum. And they have positions that they like to be in. So typically when we're in a neutral pelvis, which is basically this would be a neutral pelvis where the two hip bones and the pubic joint are in the same axis, same plane here. The bladder kind of rests on the shelf, and the uterus sort of rests on top. I'll turn it this way: bladder, then uterus, and then there's the rectum here. And prolapse can develop for many reasons, and symptoms can vary. I find in most people who spend more time kind of in more of a posterior tilt, meaning their tailbone is more underneath them as opposed to out behind them, that symptoms can be a little bit greater, and it can also potentially to a prolapse worsening. But so if we go back to this tube and we recognize that the bladder could potentially bulge into the anterior wall of the prolapse, or the rectum could potentially bulge into the posterior wall, and the uterus can descend into. Those bulges, or the descent of the organ, can create symptoms that can be uncomfortable. There could be sensations of pressure. There could be sensations like I feel like there's something in my vagina. There could be symptoms associated with if you are in perimenopause and you are still experiencing a cycle. If you use tampons or a Diva cup, maybe there's difficulty inserting it, or it feels different while it's in, or maybe it doesn't stay in. There could be pain or discomfort with sex. There could be retention of stool or urine. So there could be back pain. There's all sorts of different symptoms that could be associated with that. And symptoms don't necessarily indicate the severity of, or the stage of, the prolapse. So prolapse are typically graded in 4 stages. So back to the tube, if you have just kind of a gentle, like a tiny little bulge here or in the back wall, or just ever so slightly starting to descend, it would be a stage 1. Usually when it's about 2 centimeters, when the bulge or the organ is about 2 centimeters away from the introitus, so the introitus being the entrance to the vagina. So here on this one, the entrance to the vagina, that would be a stage 2. Stage 3 would be where you would potentially see a little bit of a bulge at the opening. And then stage 4 would be where that bulge is actually outside of the opening. So stage 3 and 4, yes, they are more challenging, and the chances of reducing or even completely eliminating that prolapse would be more unlikely. But it doesn't mean that the symptoms can't improve, and it doesn't mean that there aren't strategies to be able to these symptoms or help make things more comfortable, improve sex, improve elimination. So while I'm happy the person saw a pelvic floor physio, I was a bit discouraged by the fact that she was told that there wasn't anything that she could do. So I disagree on that. I think there's a lot that can be done. And a few of the different things would be posture education. So I'll talk about a bit more of that in a second. Diet, elimination habits, exercise and movement, and hypopressives. So I'm going to talk a little bit more in depth about hypopressives in a moment. I'm just quickly going to check the chat here. A couple people. So anybody who has questions, you can certainly just post them on the side there, but I'll just keep chitty-chatting along here. So I have a prolapse. I have a stage 2 rectocele, so my rectum bulges into my vagina. Statistically, organ prolapse is, from statistics, it's about it's a little over 50% of women have some degree of prolapse. In the early weeks postpartum, and I know that, or I'll make a sidebar that prolapse doesn't happen just to women who have been pregnant or given birth, but this statistic was interesting to me. In the early weeks postpartum, over 80% of women have some degree of prolapse, and close to 50% of that 80% have a stage 2 or greater. So prolapse is very, very common, and early stage prolapse is actually, in many cases, asymptomatic. So not a lot of women know what prolapse is, but not a lot of women who have prolapse actually even know they do, because they may not even have any symptoms, and there's nobody necessarily screening for it either. So part of the reason why I recommend that every single woman see a pelvic floor physio every year is because we have an opportunity to catch early stage prolapse, and then we're in a position to potentially even reverse it, but definitely prevent it from getting any worse. Whereas people who don't have anybody who's helping with screening and who don't know they have prolapse and actually do, it could potentially, and typically does, worsen over time. And then when symptoms start to appear, it could be at a later stage. And again, not saying that we can't make a change when it's at a later stage, but if we have an opportunity to catch it earlier, in my mind, that's better. So prolapse is very, very common. Can you watch this later? You're at work? Yeah, you probably don't want your work, not all your work colleagues to watch this, but yes, you can. I think it's recorded and it'll be put in the chat. Prolapse is very, very common, first off, to know that. I have a stage 2 rectocele, so my rectum bulges into my vagina. And I have had it, I can't remember exactly when I first found out, but it's like 7, 8-ish, 9 years maybe even. I lift heavy. I run. I exercise in all sorts of different ways. I very, 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 very rarely have any symptoms. I pay very close attention to my diet. I do daily pelvic floor exercise. I do daily, well, when I say daily, I'm going to say 4 times a week. So almost every day, but 4 to 5 times a week, I do pelvic floor exercise and hypopressives. I see a pelvic floor physiotherapist once, twice a year. So I'm very aware. I'm very on top. I manage. I am diligent with it. I'm doing my best to prevent it from getting any worse and potentially even avoiding surgery down the road. So just letting you know, I have one. I live with it. I have all sorts of different strategies to share. Early diagnosis of a prolapse can be very devastating. It has historically been associated with, being told that you can't lift anything over 10 kilograms and you can't run anymore and you can't. But you can. And it's about symptom management. So being aware of what you are experiencing and then how you can manage those symptoms and potentially reduce them is really, really important. One thing I was going to say, rectocele. So when you hear cele at the end, the cele identifies that it's something bulging into the vagina. So the rectum bulging into the vagina is a rectocele. The bladder bulging into the vagina is a cystocele. Some people will say they have a rectal prolapse, but a rectal prolapse is different than a rectocele. So you want to be able to distinguish between a rectal prolapse, which is where the rectum is actually bulging out of the anus, compared to a rectocele when the rectum is bulging into the vagina. So those are two different things, but they are often called the same. Often people call a rectocele a rectal prolapse. Other names that you might hear in a rectum, you might hear posterior wall prolapse. So they're talking about that bulge is creating a kind of a sag or a bulge in the vagina, in the posterior wall of the vagina. You might hear anterior wall prolapse. You might hear bladder prolapse. You might hear cystocele, so talking about on the front or on the bladder. So those are the most common names. And then a uterine prolapse or uterus prolapse is typically what you might hear. If you go, I'm going to add one little disclaimer here. Because I'm here on a snow day, it means my children are also here on a snow day, and I hear one of them coming in from sledding right now. I've asked them to be quiet, but just in case there's any distraction, I'm apologizing in advance. So right now what happens is when people, maybe from a forum like this, maybe they've been told from a friend, maybe they just feel like something is off, typically the first person they go see is a doctor, their family doctor. I believe we need a collaborative approach to any aspect of our health. However, I do believe that medical professionals may not necessarily be the ideal first line of defense. So what typically happens is a woman will go see her family doc, and there may be an internal evaluation. There may also be a referral. So typically there is an internal evaluation. There may be determined that it is a prolapse or maybe to do with incontinence or what have you. There may be a referral to a specialist, so a gynecologist. Typically there will be a wait for that gynecologist. The assessment by the doctor. So in Canada here, we have very limited time. So it's usually about a 7 to 10 minute visit that we have with the doctor. So you get not necessarily the most thorough assessment or opportunity to explore symptoms. So what can happen is some people may be given medication, or they may be said, go see the specialist and wait for that. What I would love to see more of, and it is starting to happen, is family physicians referring to pelvic floor physio. You don't need, at least in Canada, you don't need a referral from a physician to see a pelvic floor physio. You can call one up and make your own appointment. It is not covered by our provincial health care. If you have extended health coverage through any employment, it would be covered just like regular physiotherapy would be. And some plans do require a referral from a physician, so check what your plan requires first. But if you are feeling like something isn't right, maybe you feel some of those symptoms, or maybe one of the symptoms that I was talking about earlier, I would first see a pelvic floor physio, and they can help determine if a visit to a physician or potentially onto a specialist may be indicated. You will get a much more thorough assessment with the physio. as well as, in my opinion, more options in terms of what to do about it. So what things we can do, I'll talk about a few different ones. So pessaries are a really great option. Pessaries, I don't have one with me right now to show you, but pessaries are different shapes, different sizes, the most common one being a ring, which looks like a circle. If you've ever heard of the diaphragm for contraception, it's very similar to that. So it's a ring that is, you fold it up and kind of into, like fold it in half and then fold it over on itself. And then when you insert it and let go, it essentially opens up and it can provide support to the organs that may be descending. So it can help with managing symptoms. It can also help prevent further development of any further descent. For some people, where it also there's indications to wear one for incontinence, so stress urinary incontinence. And what it does is it actually provides a little bit of pressure against the urethra to help close it off to prevent the leaks from happening. So some people use it for prolapse, some people use it for incontinence, some people find that it's helpful for both because you can experience both. So pessaries are a really great option. The challenge with pessaries is because there are so many different shapes and sizes, it can sometimes take a couple of visits, or it can take a little bit of time to find the right one for you. Currently, right now, there are not a lot of physios who fit pessaries. So it used to be that only gynecologists or nurse continence advisors could fit them. That's starting to change a little bit now, but finding somebody who can help you fit one is the first step, and then finding the right fit is the next step. So sometimes it can take 2, 3, even 4 times to find the right one, which, if you can imagine how long it takes to make those appointments and try them out and it can take a little bit of time. So it's worth investing that time, but I'm kind of referring back to physio. Keep in mind that the physios sessions can be happening while you are pursuing these other options as well. And there are some physios who do have the ability to fit for pessaries as well. So common questions with pessaries are about people think that they are something that maybe they shouldn't use because they would become compliant, reliant. Sorry, is what I meant to say. They might become reliant on wearing it all the time. And I understand where that point of view comes from, but typically prolapse it can happen for a couple of different reasons. It might be pressure management, meaning posture or breath or movement practices that aren't necessarily optimized can contribute to it. It can also be the tissue injury. So if there were any tears or if there's any residual scar tissue from surgeries or birth, that can create a defect that maybe is contributing to the prolapse. It can be just general laxity in that tissue. So sometimes it's about genetically what type of connective tissue you have. So there's a couple of different influences there, and not all of them are within your control. And something that can alleviate symptoms, in my opinion, is a good thing. And the other reason why I believe it's really good is because when the organs are not necessarily in their optimal position and maybe bulging or descending, the muscles react to that and sometimes work differently. When the pessary is in, it can allow the muscles more freedom to work as they normally would. So it could potentially improve exercise outcomes. And from a mental perspective, again, by alleviating the symptoms, that can create more freedom in life, because it can be really distracting and discouraging and kind of interfere with a lot of aspects of our life when we're constantly aware of the prolapse. So I think they're a great option, and I would definitely pursue them. So that is one option from a prolapse perspective. Pelvic floor exercise, so Kegel exercises, are something that pretty much any physiotherapist would recommend, and they will teach them in a variety of different ways. Some people may need, let me back up, there's a couple of different aspects to a Kegel exercise. Most people associate a Kegel with just a squeeze, but there is a squeeze, kind of a drawing together, and then a lift, and then there's a let go, a relaxation phase. And most people who have been focusing just on the squeeze, or people who maybe have developed compensation patterns or certain strategies for core stability by squeezing, may be missing out on the lift and on the letting go. So it's not taking the pelvic floor through the full range of motion. So a physio, or the work that I do, helps you determine what aspect you may need to focus on, and then learn how to do that better. Another note I wanted to make on what I just said, when you feel like something is going to fall out of you, or when you feel like there's something in there in your vagina, or if you are leaking urine, or if you feel like you're always needing to go to the bathroom all the time, you will develop, often unconsciously, sort of holding patterns, tension, gripping, where there's a tendency to kind of want to like bring your inner thighs together or squeeze your glutes, cross your legs, in thinking that something is going to come out of you. And so over time, the body adapts to those strategies, not necessarily in a good way. And so sometimes learning to do Kegels is unlearning some of those compensation strategies and then relearning how to take the pelvic floor through its full range of motion. So pelvic floor exercise is a really, really good option. I just posted a video on my Instagram and my Facebook page, both are Vagina Coach, about Kegels, and I use my vulva puppet, and there's all sorts of visualizations in there. So I'm not going to go through that here. You can go and look at that video on your own time, and another time, to learn how to do Kegels. But seeing a pelvic floor physio will definitely, they're kind of like the gold standard, I would say, in terms of you understanding what your pelvic floor would benefit most from, whether it's the lift or the squeeze, or if it's the letting go. If you don't have access to that, you can use your own fingers. You can use a partner's fingers. You can use a partner's penis. You can use, there's some biofeedback toys. The one that I like the most is called the Elvie, E-L-V-I-E. Those are all tools that you can use to help assess if there is a squeeze, if there is a drawing up, kind of a lift, and if there is a letting go, and if it happens in a balanced way. So Kegels can definitely play a role in helping manage prolapse symptoms and incontinence. So what I'm talking about mainly right now is prolapse. I will address incontinence in a second. But pelvic floor exercise definitely plays a role in the potential improvement of symptoms and the management of prevention. So preventing a prolapse from getting worse, or from other ones developing. I'm going to talk about hypopressives, but I'm going to make one more comment first before I go there. Surgery. So especially women who are finding out about a prolapse at a more advanced stage. So when I say more advanced, usually stage 3 or 4, typically the recommendation is surgery. And surgery can be life-changing. It can be very well indicated. It can be chosen. But what I want women to know, if they do choose surgery, or if it's indicated, the outcomes of that surgery, in my opinion, would be improved with pelvic floor physio as prehab, pelvic floor exercise as prehab, hypopressives, and also using those 3 things as the rehab and ongoing maintenance as well. So what commonly happens, whether it's for prolapse or for incontinence, for people who have surgery, it addresses the symptom and often eliminates the symptom or symptoms. And that's life-changing, and that's liberating, and it's amazing, and people feel like themselves again, and they will often return to fitness activities, which we want to have happen. However, some of the contributing factors to why that developed in the first place haven't necessarily been addressed. And the likelihood of a prolapse returning or another one happening is higher. So the chance of having a subsequent surgery once you've had one is, I forget the percentage, 30-something%, I believe. So it's quite likely that you would have need a follow-up surgery. And a lot of people say, well, I had that surgery, but it failed or it didn't work. And it's not necessarily that the surgery didn't work, it's the strategy that contributed to the problem in the first place wasn't addressed. So in addition to that, when you have surgery, there is injury, if you can say, to the tissue, to muscles, to connective tissue, to nerves. And that can affect how that system will work on an ongoing basis afterwards. And so that needs to also be addressed from a retraining perspective post-surgery as well, so that you can return to optimal pelvic floor, contract, like lift, let go, all that kind of stuff. Otherwise, sometimes new challenges can come about after surgery. The other thing that can happen after surgery is some people have prolapse surgery and then afterwards they realize they have incontinence. And sometimes prolapse can mask incontinence. And then once the prolapse has been fixed, the problem of leaking that was always there is now more prominent. So it's really, we need to address the global core unit, the core system, rather than looking specifically at isolated little spots and potentially fixing that. So that's my note on surgery. I also recommend that you ask the physios who the good surgeons are, because they are the ones that typically see the work of the surgeons. It may mean that you meet a couple of different ones until you find somebody who you trust and who makes you feel comfortable and you feel is addressing the right things. Hypopressives. I'm just going to see if there's any questions here. No, okay. So hypopressives are something that I recommend for, I use them with pretty much every single one of my clients, but especially women who have prolapse. Before hypopressives came on the scene, there really wasn't a whole heck of a lot that was offered as ways to help manage or improve prolapse from an exercise and movement perspective. It was, as I mentioned earlier, usually, you can't lift anymore, or be careful how you do this. I wouldn't run anymore, no more jumping, all that kind of stuff. So the term hypopressive means low pressure, low pressure. Much of running, jumping, lifting, all the other things we do in the day would be considered hyper, so high pressure. And we want to be able to have the hyper, we want to be able to lift, we want to be able to run without symptoms. And one thing that has helped with that, managing symptoms, reducing pressure, improving posture, and even reducing the grades of prolapse is the hypopressive method. So it was found out or created by a male physio in, I think he was in Belgium or Spain. I can't remember which one he started out in, but he was using a speculum with a client that was cold. And when he went to insert the speculum, the woman sort of drew back because she was a little bit startled by the coldness of it. And what he witnessed was her prolapse retracting. So he tried to recreate what she had done in her body to make that happen. And that's essentially how the technique came about, how it developed. So it's been used around the world, but mainly in Europe for, I think it's close to 30 years now or so. And it's been around in North America for probably the last 9 or so years. And when it first came to North America, so the first class that was taught here in Canada, I attended with a bunch of other pelvic floor physios and some other fitness people like myself, and we all sort of went in quite skeptical because when you first look at the technique, it looks like it counteracts or is counterintuitive to a lot of the other breath and posture type things that we teach. But we went in and by the end of it, we all left and went away and started to do it ourselves. We started to do it with clients, a couple physios who worked mainly with pain populations and who worked mainly with people who had very high tone. So the people who have more tension or overactivity in the muscles, they were quite skeptical on that, but they ended up seeing that those people, their tone would come down, their tone would normalize and pain would decrease and the tension would lessen. People who were hypotonic, meaning that had less tone, little tone, who needed to work more on the contract and lift, kind of the up training aspect, hypopressives worked to normalize their tone by elevating it. So high tone was coming down, low tone was coming up to kind of normalize tone. That was the term that I guess we generally use to describe that. And so anyway, so we've been using it now for however, I think it was again 9 years or so ago when we first took that course, and a friend, colleague of mine has created Hypopressives Canada, and she's now been teaching other professionals around the country for several years now. And it's something that I use myself. What I have found in my own self, in my clients, and what collectively people who use hypopressives have identified is that the technique is not as effective with rectoceles. It's very effective for bladder and uterine prolapse. So cystocele and uterine prolapse. That's not to say that there isn't any influence on a rectocele, and I think that when there is a rectocele, when there is a bulge in the abdominal wall, there is also an additional lack of support for the uterus and the bladder. So having something else to kind of counteract that is helpful and beneficial. And then the voluntary pelvic floor, like Kegel activities also work on building up strength and endurance and suppleness and response in the and kind of bulk in that group of muscles as well. So I kind of feel like the hypopressives balanced with what I term Kegel mojo work is really, really beneficial, and it's basically my pelvic floor fitness plan from here on in. I've been doing it for years. So when you see hypopressives done, it looks a little bit odd. It looks like I'm sucking my abdomen in. And sometimes you might, if you've ever seen little kids, sometimes little kids will come and they'll kind of suck everything and they flare their ribs out and they walk around like this and they think it's funny. It looks very similar to that, but how we get to it in hypopressives versus how the kids would get into it, or how in yoga there's something called Uddiyana Bandha, how they get into it is more of a voluntary movement, whereas in hypopressives it's involuntary and it's a response to a full exhalation of all the breath, and then an false inspiration, meaning you try to take a breath in with your glottis closed. So when no air comes in, and you're trying to take a breath, the diaphragm remains elevated and creates this kind of suction or drawing up of the organs and the viscera, and so it's really, really effective. So I'm going to show you how to do that. It will look a little bit odd, and while I'm in the apnea, and when I have created that suction, it will be, I can't talk. So I'm not going to be able to necessarily tell you what's happening, but what I want you to see is I want you to look at my abdominal wall, and I will put my hands on there to show you that I'm not engaged. It's actually soft. It's not contracted and rigid. So I want you to see that. and see, I'll sort of turn sideways and you'll see that there's kind of a concavity that happens where the ribs will flare out and the abdomen kind of draws and scoops upwards. And the other thing is you're going to I'll point out here, pay attention to what happens, right? You can see from the pressure that happens, and we always have intra-abdominal pressure, and we're kind of playing around with that pressure, and you'll notice a little indentation will happen here as well. When people are first learning, I usually have them first learn when they're on the ground, lying down on their back, so that there's no influence of gravity. And I'll show you standing up so that I can kind of turn my body around to show you. Standing up is a little more challenging, a little more difficult for people to feel or sense, but it'll give you a kind of a visual opening. And I'm just going to see comments here. Can anything be done for Rectocele? I'm kind of on right now. I'm sorry if you covered this already. I missed the beginning. Hope you did it. Okay. So just on that note with Rectocele, so hypopressives. So for me, my Rectocele I do hypopressives every day. I do all the other stuff, and my Rectocele hasn't changed, which is good and bad. So it would be great if it would reverse, but it hasn't. It hasn't actually lately from diet changes. Mine improved ever so slightly. So I'll talk about that in a second. But from an exercise point of view, usually Rectoceles don't necessarily change all that much. It's not to say symptoms can't change, but the stage may not necessarily change. So I'm going to show you a hypopressive. It's best if you have, I'm going to tuck my stuff up so you can kind of see what's happening. It's best if you haven't eaten, because as you can see, or if you can imagine, if I had food in my belly, when you see what happens in a second, you'll know that it wouldn't feel great if I had a full belly. I'm not going to go too particular into the different arm positions and poses, but just kind of give you an idea of what's going to happen in my abdominal wall. And I also want you to watch my belly button. So kind of see that there may be almost a little bit of that happens as well. When you're first learning it, so I've been practicing this for a while and I can get into it without plugging my nose, but people are first learning, they would need to close their mouth and then plug their nose, and then I say, now try to take a breath in, and that creates that involuntary response. So I'll show you both ways, getting into it that way and getting into it without. But okay, so I'm going to take a breath in, and then I'm going to exhale all of my air very softly. And now I'm going to do an apnea, so my air is still exhaled, and I can't talk anymore after this. So when you've gotten into an apnea and when you come out of it, typically when you feel like you need to take a breath, it's almost like you're breaking a seal and kind of air will rush in. So that's typically a sound that you might hear. So now I'll just show you what's happening here. And then I'm also going to show you my back. So another kind of indication that you are in a good apnea is what you might see at the back as well. And this time I'll show you as if I'm plugging my nose like a client would. So I'm going to take a breath in. Typically you take 3 breaths first before you go into an apnea, but I'm just condensing it down for you right now. So breathe in and exhale. Close my mouth. So that's basically what it looks like, and it looks kind of weird. And when you first are trying it out, I remember before I had learned how to do the technique, I found it on the internet, and I was going on one video, And I kept studying this video and trying it and trying it. I was trying it in different positions, and I couldn't understand what she meant. This person who was doing it online, I couldn't understand what she meant, what she was trying to. And after, I don't think I tried it over 4 or 5 days, and then finally one day it just did it, and I was like, oh, that's now. And so I felt a very deep kind of drawing up, a deep activation almost in the kind of the top part. So almost like right here, it felt like somebody had their hands inside me on my tissue and was lifting up. And yeah, it felt lovely. It felt really nice. It's very challenging. So as you can feel like here, even just doing that one time, you get out of breath a little bit. So it's a really amazingly energizing yet calming practice. So I find it kind of like moving meditation. You're counting your breaths, you're counting the apnea, how long you hold your breath for. You're going into various poses, and I find it's very methodical, and I find that I just basically focus on that, and everything else is kind of non-existent in my world for that 10 to 20 minutes each day. So I'm just going to go through a couple questions here. Prolapse, pressives, and come back to other. Are you performing a Kegel at the same time? No. So the philosophical principle behind the original hypopressive technique is that it works on the involuntary aspect of our core. Kegels work on the voluntary aspect. And having a combination of both is a good thing. There are some people who find that they get a better lift or a better sense of depth of their apnea if they add a Kegel after they're in the apnea. So once I had exhaled my air and you saw that concavity, once I was in that, you can add a voluntary Kegel. What I find personally in my body is in some positions, in some of the poses, when I do that, I find that the depth of my apnea, so that kind of that deep drawing up sensation lessens when I do a pelvic floor contraction. And there are other poses where I find that it doesn't make that much of a difference. So personally for me, and the way I teach it is we do enough of the voluntary. If you're working with me, you're going to be doing voluntary Kegels already. Let's focus on the involuntary aspect and do the true form of the method if it manages symptoms for you. So if you notice that you feel better when you add Kegels, then totally do it that way. But the true protocol itself is to not add Kegels to hypopressives. Another question, I'm 50 next month and have started needing to urinate more frequently. I've only had leakage a couple times when I sneeze. What can help this frequent urination? If I drink water, it just runs right through me. So I'm bringing this question in because hypopressives can also help with incontinence. Now, not necessarily urgency. So the kind of what you're describing, the need, you're kind of describing a couple things. Yours is more frequency. So it wouldn't necessarily address frequency per se. And there's other things that I'll talk about right now that I think we can address frequency with. But hypopressives is beneficial for prolapse for sure. And there have been people who have reversed early stage, so stage 1 and 2 reversed prolapse completely. And there's other people who have reduced by a stage. So in November, I had 3 clients who all had stage 3 cystoceles, and bladder prolapse. And one of them I have not had the follow-up with yet after she has seen her physio, so I don't know what her improvement is as of yet. Her statement of improvement has been a reduction in symptoms, and she feels way less symptomatic and way stronger, but I don't know if there's been any change to her position. The other 2 both brought it up a stage, so they were no longer stage 3, they were at a stage 2. One was using a Pessary in addition to hypopressives and Kegel Mojo stuff, but I actually just got a testimonial from her, it'll be up on my website, but she was it was life-changing for her. So she had one child. She's in a very busy, up, moving around all day job, and she was very symptomatic. She was a runner, a climber, all very, very active, and she had it just kind of brought everything to a grinding halt. So she was able to get back to absolutely everything and really, really symptoms well. So she had a reduction in symptoms as well as stage. And then the same with the other person as well. So it can be incredibly, incredibly powerful for prolapse and really gives people hope. Whereas before it used to be, well, sorry, you can't run anymore. Sorry, you can't lift anymore. Sorry, you can't do this and can't. Bladder, incontinence wise, it also helps with it balances and normalizes the tone and the function and the coordination of that inner core unit, which also then can help with incontinence. From a frequency perspective, I immediately go to have people complete a Bladder Diary. And I've just switched to a new website platform, so my Bladder Diary link is not yet up on my site, but I will post it in here, and I will also have it up on my site shortly. But I invite you to complete a Bladder Diary, and it asks you to record what you eat, what you drink, the time of day, how many times you pee, like what time of day you pee, how much volume comes out. So I recommend you buy a set of measuring cups from the dollar store and use those, and then don't ever use them for your baking or anything after that. But measure how much volume is coming out as well. Because frequency often is habit. It can be habit, and it can also be food and things that might trigger the bladder to want to eliminate. So if there's caffeine, artificial sweeteners, acidic foods, chocolate, alcohol, there's many things that can irritate the bladder. And there are things those are kind of the more common, but there's other people that may have food sensitivities that are also having inflammation and potentially irritation that could contribute to the frequency. Also, the volume in periods of time. So some people stop drinking because they're going to go exercise, or because they're going to go for a long drive, or because all these reasons. And then the urine becomes concentrated, and then will start to irritate the bladder and want to come out. So that can contribute to actually needing to go a little bit more often before the bladder is full. And then sometimes those patterns of peeing just in case, because you don't want to leak or because you don't want to get that sense of urgency, trains the bladder to signal you more often. So I address all of those things first when we talk about frequency. There can be something called overactive bladder, which is best managed with medicine, but I want to rule all the other stuff out first before we go down that route. But I would complete the Bladder Diary and check out, start to pay attention to things like caffeine, for sure, is definitely one. And the times of day and the volume you drink at certain periods of time. So water throughout the day is best, as opposed to chunks of time. Hopefully you find that helpful. Hi, Allison. Just stumbled on this video, but boy, did I need to hear it. Thank you. Oh, good. I'm glad. So I've got about 10 minutes left, and I was going to say something else. So hypopressives, I'll elaborate a little bit more on that, I think. Hypopressives are, when I'm first starting to work with somebody as they're learning or as they're becoming trained in it, typically I give them between 1 and 3 postures, depending on the person, depends on how quickly they learn the technique and grasp the apnea. And the position may be different. Most people start on their back, and then I'll send them off, and they will go and do that for a week or two, and they'll do it every other day or every 2 days, and they'll do anywhere between 3 to so depending again how many poses they have, but do hypopressives for about 5 minutes, practicing getting used to the technique. And then we start adding on poses and different positions. So some will be seated, some will be standing, some are kind of in like an all fours position. So we play around with the influence of gravity. And as I mentioned before, standing up is typically the hardest ones to do. And then when you start to add movement, as you start to get really, really adept at hypopressives, that becomes even more challenging. But early on, it's finding the pose where you can get the best apnea, becoming well practiced in that, and then layering on additional poses, building you up to a point of doing a routine that takes you about 15-ish, maybe 20 minutes per day. And there's a principle of in fitness, it's called time under tension. So if I had say I had a dumbbell here and I'm doing a bicep curl and I do them at this rate, there's a certain amount of time that my muscle is experiencing the load of that weight. If I slow that down and I do the same number of repetitions, the same exercise, the length of time that my muscle is under the influence of that load is greater when I move slowly. So by adding on poses and poses basically in hypopressives to extend the amount of time, it's kind of like increasing that time under tension. It's increasing the amount of time that core system is asked to respond. So it kind of there hasn't been, at least in my, recently I asked the question again, none of their research or suggestions have said that 15 minutes is best or 20 minutes is best or 25 minutes is best, but a general consensus is between a 10 and 20 minute window of hypopressives each day would be considered kind of the goal or the ideal. And so it's best done on an empty stomach. In an ideal world, it's done earlier in the day. So usually I wake up in the morning, I have my poop, I do my hypopressives, have breakfast, and then I might do whatever my other workout is. My hypopressives, for me, my routine takes me about 10 minutes. So I've done it for many, many years, and the length of time that I hold my apnea has increased, but the rest breaths that I take in between those apneas has decreased. And so as you become more trained, you're kind of always playing in that 10 to 15 minute-ish window. But general principles are not on an empty stomach, doing it earlier in the day, and nobody, and I don't think there's many people in this group who are pregnant, but not to be done while you're pregnant, and not to be done if you have hypertension, high blood pressure. So those would be, pregnancy and high blood pressure are the two contraindications for this technique. The poses of the technique, which are considered low pressure, can be done, but the apnea, which is the breath in that drop, would not be done. If you were on blood pressure medication and you had clearance from your physician to do it, then you can. It can, but I'm blanket statement saying you would need clearance from a physician first and to have your blood pressure under control first before you do it. So that's kind of the general gist of hypopressives. I think it's an incredibly, incredibly powerful tool, especially for prolapse. It gave women with prolapse hope, and it makes them feel like they are doing something that's hard, and they don't just have to do little, core retraining, dinky, to use the most common term, exercises. But there's also, there was another, I can't remember the type of study, retrospective, I believe. It was something like 4,000 women, and there's a physio in Australia who put a questionnaire out to women with prolapse, and it was over 4,000 women, and I believe they had 3,000 something responses back. And it was trying to determine if lifting, so heavy lifting, weightlifting, would increase or decrease prolapse symptoms. So not looking at the stage of it, but the symptoms associated with it. And the overwhelming response was lifting, so heavy exercise, weightlifting exercise, improved symptoms. And there's also another physiotherapist who I respect greatly. His name is Anthony Lowe. He's out of Australia as well. And he kind of came onto the pelvic floor scene posing some very interesting questions. And initially we were all kind of, a little bit skeptical, But what he really did was introduce the, I don't know the word I want, but he was trying to get people to question what has been prescribed for so many years with regards to prolapse and movement and exercise. And what's happening now is there's a lot more freedom of movement, and women are more liberated and taking more with regards to exercise, and to recognize that it's not making things worse. In return, it's actually also making, or in reverse, it's actually almost making things better, even if the stage doesn't change, but the perception of symptoms changes, which can do a lot for the kind of mental health as well, but also the physical health, because by not moving, we become deconditioned, and that then puts us down a path of other health symptoms potentially showing up. We are designed and need to move and benefit from movement and exercise, and we need to load our tissues in ways that asks them to adapt to that. If we are always lifting a 2-pound weight and we don't reach the point of feeling like, you know, that's too much or too heavy, the body won't necessarily adapt to that. Sure, that movement is still better than not moving that arm, but there's no load that is asking the body to improve. So when we introduce opportunities for our body to respond in ways that it does need to improve, it will. So move when you have incontinence, move when you have prolapse, but move in ways that you can manage your symptoms. And then we start to kind of push the boundary a little bit. So some people will say, for instance, running. I usually start to leak after 20 minutes of running, or after 5K. So let's run until 19 minutes and work on retraining the system. And then eventually we'll go out to run and reach the 20-minute mark and not leak. And then eventually it's 21 minutes and 22 minutes and so on. So we want to kind of train in the symptom-free zone periodically, temporarily, while we retrain the system, and then eventually be pushing the boundaries so that we are, so that we get back and we progress and we move beyond. A lot of women get back to doing things and start lifting heavier than they did before they had a prolapse, or before they were pregnant, or before they had incontinence, or whatever it is, because they've now retrained that system, and they develop, they harness their opportunity to get power. That's our power center. Our pelvis is our power center. And when we have prolapse, or when we have incontinence, there's power and confidence and potential that's leaking out of us. And so we want to be able to get that back. So I am time here. I'm just to see if there's any loud thing. We're located. I'm right by Shirley. I'm in Port Moody, BC, but most of what I do is online. So I have online programs and I do online coaching. So it doesn't matter where. Let me see. After an odd dream and bladder sensation last night, this was my timely spirit message for me. I trust my body wisdom and higher intelligence of being and guiding me to where I need to be. That's awesome. Thank you for sharing that. Okay, that's it. So thank you for everybody who participated and was here. And this will be posted in the group for later. And if you have any questions for me, you can send me an email, kim@vaginacoach.com, or you can tag me in this group. I think it's a great place to do that, because there's probably hundreds of other people that have the same questions. So it's a great opportunity to introduce concepts to other people by sharing your experience and questions in the group. So you can reach me through there. And that's all. So thank you very much. And if you are in Vancouver, I hope you are safe and warm inside and don't have to drive anywhere. Okay, see you later. Bye.